So without further delay, I'm just going to start. Has everybody uploaded their presentation? All of you all? So we can start. Okay, I'll talk to you very briefly. Right. Yes. Okay. So, get a presentation. Right. So I'd like to call upon Manaswini first. Yeah, please. So your presentation is going to be on correlation of macular ganglion cell thickness and visual acuity with visual acuity field indices in papilledema. Ah, wait.
It has changed, sir. The other first one. This is another presentation. Can you show
Eight
mine?
and
This one. Second from last. Yeah. Good morning, everyone. I'm Dr. Manaswini. Today I'm going to talk about the correlation of average macular ganglion cell thickness with visual acuity and field indices in papilledema. So, it's not moving. So, sorry. It's faulty. This system is. Can you can you project it from the beginning? Ki- Yeah, so we all know papilledema without any identifiable organic cause is idiopathic intracranial hypertension. So usually papilledema in acute stages will cause a severe decrease in visual acuity and visual field indices. And we know that there is a thickness of thickening of the RNFL in the acute stage, but the variability is there. When in some cases there might be an RNFL increase without a simultaneous decrease in the visual acuity. So we thought that identifying macular GCC thickness also along with RNFL might give us a better identification of the severity of disease. So we have conducted a cross-sectional observational study with 70 patients in a multi-specialty hospital. 2 patients there was attrition, sir. So we included IIH all patients, all genders, and we have excluded papilledema of any secondary other causes. So from our results, we have seen that 14 out of the 68 patients had severe thinning of the macular GCC. And out of the 14, 13 patients had severe decrease in the visual field indices along with the raise in pattern standard deviation score on HVF 30-2. So out of the 14 patients, 8 patients had drop in best corrected visual acuity to 0.3 logmar units, and 7 patients had simultaneous thinning of RNFL and macular GCC. So from the study, we have observed that there is a positive correlation between RNFL and macular GCC to the visual acuity. However, the correlation coefficient is slightly higher for the macular GCC over the RNFL. So from this, we have observed that patients might have normal RNFL thickness with decreased macular ganglion cell thickness in the chronic disease or in the severe disease. So we conclude by saying that there is a consistent trend in the consistent trend of decreasing best corrected visual acuity, visual field indices and pattern standard deviation with a drop in average macular ganglion cell in thickness in papilledema secondary to IIH. So the combination of assessment of RNFL along with macular GCC seems to be a better indicator of the severity of the disease over using only RNFL alone as an indicator. However, this is not a prospective study, so we cannot give about the progression of the disease. Thank you, sir.
It's a great presentation, a great idea also, because now the trend is towards having as many data sets. So RNFL alone may not give you as much information as well as RNFL and GCC. So that's a great point. Suppose you're doing a visual field and you have papilledema. What are you expecting?
So usually, sir, in acute stages,
Right.
there may not be severe drop in the visual field also.
Right.
Because
But what is the most common type of thing that you would like to expect? Is there a particular type of scotoma that you expect?
any blind spot
Right,
enlargement or any
that's great.
circumferential
So
field.
there might be just a blind spot enlargement. So you got to look for it, otherwise you're going to miss it.
Yeah.
That's
So
the issue.
we have actually tried to quantify the visual fields also, sir,
Right.
because just seeing the type of visual field effect is subjective.
That's true.
So we tried to do visual field index and pattern standard deviation along with the macular
No,
GC.
see, visual field index is going to be a problem. I'll tell you why. Visual field index, what is visual field index?
It's the total amount of visual field that is present in the patient.
Right, but what's atypical about it or what's special about it? What's special is the central points, they are given more weightage compared to the peripheral points.
Yeah.
That means if you have a drop in a central
Macular GC.
central DB, that's going to give you a larger drop in VA5 percentage than a peripheral drop. So in papilledema, VA5 may not give you a larger drop.
Yes.
Do you understand? Because the points are peripheral. The scotomas are peripheral. But it's great. So we'll move on. As it is, I'm late. So it's a very good one. Very nice. So we'll move on to the next presenter. Is Shrishti here? Shrishti Agarwal? No. So the next presenter on the list is Nayana. Please. So her presentation is going to be initial experience with dichoptic treatment in amblyopia. Please, please.
So I will be talking about the initial experience with dichoptic treatment in amblyopia. So as we all know, amblyopia is a visual developmental disorder consisting of reduced best-corrected visual acuity in one eye or rarely in both eyes without the presence of any ocular pathology. So in addition to the reduction in the visual acuity, it is accompanied by the binocular dysfunction also in many cases. So the conventional treatment, as we all know, includes the occlusion, atropine, penalization and all. But the newer therapies are also on its way, including the dichoptic treatment. So our aim was to evaluate the efficacy of dichoptic therapy in the management of anisometropic amblyopia. So we tried to study the improvement in visual acuity and also the improvement in binocular functions in patients with anisometropic amblyopia with dichoptic therapy. So we have included children above 6 years or adults with anisometropic amblyopia who are willing for the therapy and who have already done patching for 3 months and failed. We have excluded amblyopia due to other causes, any history of previous surgeries, developmental anomalies, developmental delays, and large angle squints. So 9 children were included in the study over a period of 6 months. A detailed history and examination of the anterior and posterior segment were taken, and the best corrected visual acuity was recorded with cycloplegic refraction was done, and the orthoptic evaluation was done, and the dichoptic therapy with binocs consisting of sessions of 40 minutes daily, 5 times a week for 6 weeks. That is a total of 30 sessions were given, and the initial assessment were done after 2 weeks, 4 weeks, and 6 weeks. So the mean age was 11.9, and more males were there in the study, and an improvement in BCVA was seen in all the patients. And the pre-treatment mean BCVA was 0.347 plus or minus 0.172, and the post-treatment was 0.178, with an improvement of 0.169, which is statistically significant, with a p-value of less than 0.001. And so to conclude, dichoptic therapy can be an effective alternative to the conventional treatment modalities for amblyopia and can be considered in cases where the conventional treatment strategies fail. And there is an improvement in the binocular dysfunction also, that is the stereopsis improvement was fine. So many of the other studies were done in patients who are not done any patching or anything previously, so a little decrease in the visual acuity was seen in our study compared to others. And the small sample size and the shorter duration were our limitation, and we have to extend the study to ametropic amblyopia, and a longer duration and larger sample size is required for the future improvement of the study.
Very,
Thank you.
very nice presentation. For those who are not really aware, what is dioptic treatment?
Dioptic treatment is a binocular stimulation treatment, sir. It is a cloud-based software.
Yeah.
So
So basically, like I'm from Disha, so what we're doing is, so you have to buy the software from a particular
Yes.
company. So it could be a Binox or anything,
Yes,
and
sir.
then that software, the patient goes back and practices on a laptop
yes,
at
sir.
home.
At home.
So it's just stimulating your eyes.
Yes, sir.
But what is interesting is what we have found, our study is a little bit different. So what we have found is we are not getting a improvement in terms of visual acuity. What we are getting is a improvement in terms of patient's well-being. The patients are saying, doctor, I'm feeling great. I'm seeing better. But the visual acuity is not improving. So there appears to be something we can measure and there is something that we can't measure. So, this is probably improving some function which we can't measure as of now.
But we are.
It's a subjective, yeah. There's something else.
But we are getting an improvement
Yes,
in the
you're
visual
getting, so it's
acuity
great.
and
Yeah,
also
yeah.
the stereopsis.
Right. So,
both are improving.
there are these mixed results coming in. Are you using it for adult amblyopia also?
Yes, sir. We are extending the study. Now we have included up to 21 years. That was the maximum we have done now.
Right.
But
So,
it is.
yeah.
It
So
can
we are
be
we are
extended
trying
for
that too. So we are trying that too. And again, the results are a little bit. There are some people who are showing an improvement of a couple of lines, but it's more of a subjective improvement as of now. But it's a great, great study. There are a lot of companies who are jumping into this space. So let's see how it works out. It's work in progress.
Yes. Thank you, sir.
Very nice. So I'd like to call upon Priyadarshi. Priyadarshi is no. Okay. So I'll call upon Lakshmi. Please. So this is interesting. Effect of silicon oil injection on CCT. So it's very interesting. I'm definitely interested.
A warm good morning to one and all. I'm Dr. Lakshmi. The study is talking about the effect of silicon oil tamponade on the central corneal thickness. We all aware that silicon oil is the most commonly used intraocular liquid tamponade for a complex vitreoretinal surgery for the regmatogenous retinal detachment, tractional, traumatic artery in case of endophthalmitis, or as a first procedure in case of macula hole also. But though since it has more added advantages when compared to gases, because the silicon oil remains stable in the eye, and it is unaffected by the atmospheric pressure, so high altitude travels can be advised. But however, the use, we all aware, the use can be associated with certain potentially vision threatening complications like glaucoma, keratopathy, retinopathy, cataract as well, and if it remains for longer time, it can go for emulsification, which are based on some certain microstructural changes and clinically detectable alterations. So increase in intraocular pressure, that is ocular hypertension, presence of glaucoma during early and late post-op, and chronic rise, we all aware. Also, it can potentially alter the corneal biomechanical parameters like corneal resistance factor, hysteresis, as well as central corneal thickness. So what happens, we all aware that if there is any change in the central corneal thickness, it can influence the intraocular pressure measurement. So hence we plan for a study to define the influence of silicon oil injection as when it is used as an endotamponade, because the central corneal thickness is a sensitive indicator of the endothelial physiological functions, and it is directly related to your functional measurements, that is central corneal thickness. So it was a prospective study, included 40 eyes of 37, 34 patients with the single and 37 with single, and 3 patients with both eyes after getting the consent. Inclusion, we all aware that any patient requiring VR surgery with silicon oil internal, and exclusion criteria, any corneal pathology, any healed corneal ulcer, any dystrophy, degeneration, or in case of any cataract surgery in less than 3 months, we have included as well intraocular inflammation. So materials, common indications when we noticed were high risk proliferative diabetic retinopathy with fractional retinal detachments, rhegmatogenous retinal detachment, and one case of macular hole and one case of post-op endophthalmitis. Surgery was done by 4 different surgeons with the 25 gauge TPPV, and the silicone oil viscosity, majority of the cases we have used 1300 centistrokes except for one where it was a complex and the risk of PVR was there. So we measured the central corneal thickness with optical pachymetry prior and post via surgery. For day one, as we felt many of the patients, they couldn't cooperate, they were blinking and they had painful. Some of them had corneal epithelial debridement to enhance the visual, the VR surgeon for the visibility of the media. So it was misleading us. So what we decided, and some of the patients when they cooperated, the value didn't change pre-op and post day one. And when we repeated at week 1 and 1 month, and there was not significant, so we took the average of these values. And we compared with the pre and post-op value and age, diagnosis, lens status, and statistical analysis based on parity. And this I have represented the diagrammatic. And the range of age group between 12 years to 78, average age was 49, and males were predominantly seen, and right eye 13 and left eye 27. Age-wide distribution, I have given the bar diagram. The x-axis being the age group, and y-axis we have the frequency. So if you see, majority of the patients were in the middle age group, 35 to 60, and next comes your above 60 years of age. So the causes when we see, sorry, this is obscuring the thing. So when we see the first one, 24 majority of the cases were seen in high risk PDR, where we had vitreous hemorrhage and tractional retinal detachment. And out of this, when we see the lens status, majority of them had, of course, 98% they had a phakic and one was pseudophakic eye. And retinal detachment, that is rhegmatogenous, included traumatic. 7 cases were phakic, and 6 cases, out of 14, 7 with the phakic, and 6 with IOL, and 1 was aphakic. Post-op endophthalmitis in 1, of course it is pseudophakic, and 1 macular hole surgery case. When you see these graphs, we compared the CCT range and the frequency. X-axis, again we have classified the range of central corneal thickness in micron meter, -5 to 35 microns, and above 35 to up to 75, and above 75 and 105, and above 105 up to 165. So if you see the range, we have seen highest in one patient, and -5 also we have noticed. It was lesser than the preoperative. In that case, we had combined retinal detachment with choroidal detachment. And age-wise, if you see central corneal thickness, it was there was increase in younger age group when compared to the elderly. Okay. So it was statistically significant. The p-value found it to be lesser than 0.002, a surprise, and the t-stat value was 6.8. So what we concluded, we all know, since we know the glaucoma is a potentially, common side effect seen after silicone oil, and the silicone oil, since silicone oil itself can increase the intraocular pressure, but when we have erroneously increase in central corneal thickness, that can mislead us that actual, it can mask or overestimate the IOP rise, because the treatment is based on our IOP rise. We shouldn't give aggressive treatment without considering our central corneal thickness. So there are so many corneal remodeling changes during acute and early late phase. Because of the endothelial cell, the pump mechanism fails. Hydration increases. Chronic cases, stromal thinning, it will lead. So the limitations, it's a small number. Further, we couldn't measure post silicone oil removal, we couldn't assess. It would have given more insight into this thing. Thank you so much.
So it's a great study. It's very difficult to actually, because specular as an instrument, what did you use to calculate the
So I mentioned optical biome.
So that itself is a little bit flawed. There'll be some of my phaco cases where pre-op, the endothelial cell count, it's going to be different, the picture is different. Post-op, it looks better, which just can't be. So it is a little bit flawed, the exact measurement. Measurement of the cell counts as well as the thickness with an optical instrument. There's no other way to do it. That's the only way to do it. That's A. And B is, once an eye is subjected to something like a VR surgery, I've seen VR surgeons. Is there a VR surgeon here? So who just scrape off the epithelium like anything. We are told to respect tissue. So they are more concerned about what's inside rather. So
Media
it's a little, yeah.
clarity.
So for the media clarity. So it's a little bit difficult to do this study properly, but it's a great effort. Great
Thank
effort.
you so much. Thank
Very nice. So we'll move on to the next speaker. Is Shogoto here? So please. So Shogoto is going to present bilateral optic neuropathy in pediatric SLE with no visual symptoms. So that's a very interesting case.
So, good morning everyone. Today I would like to share an interesting case of bilateral optic neuropathy in a pediatric systemic lupus erythematosus with no visual symptoms. We all know SLE is a complex autoimmune disorder which affects almost every ocular structure. Among them, 1/3 of the patients experience eye involvement. Optic nerve involvement in SLE is very rare, and bilateral optic neuropathy in pediatric cases is seldom reported. In maximum of the cases, seropositivity with APLA and NMO is noted. Few APLA and NMO negativity has also been reported. But in every reported case, symptoms of vision loss or ocular pain was present. So a 10-year-old girl presented with SLE pancreatitis treated with IVMP with azathioprine and hydroxychloroquine in April of 2019. First eye checkup was done, which was within normal limit. Then, due to COVID-19 pandemic, the girl child lost to follow-up. Then again, she presented with grade 4 lupus nephritis in March 2021. In July 2021, she experienced PRESS, which was managed by anti-epileptics near her home. Again, in August 2021, 3 doses of IVMP and second dose of cyclophosphamide was given due to increased severity of pancreatitis. Second eye checkup almost after 2 years was done when she was admitted for 5th dose of cyclophosphamide on December 2021. Patient had no ocular symptoms. Ophthalmological examination showed 6/6 uncorrected visual acuity with color vision, pupillary reaction, IOP, anterior segment, all normal. But on fundus examination, we had found bilateral temporal pallor, which persisted in August 22 also. OCT, Humphreys visual field, was not very much reliable due to pediatric age. APLA, anti-NMO, anti-MOG antibodies were negative, but VAP showed bilateral prolonged P100 latency and decreased amplitude. MRI, as we can see, shows optic nerve hyperintensities on both sides, and contrast enhancement was avoided due to grade 4 lupus nephritis. So in SLE optic neuropathy pathomechanisms, we have got thrombotic and immune-mediated vasculitis reported in the literature. Early treatment with cyclophosphamide and azathioprine have shown good visual recovery in SLE-associated optic neuropathy. Our case was asymptomatic and has good vision. Likely the reasons could be bilateral small vision loss could not be appreciated due to young age of the patient, rapid improvement due to coincidental treatment with cyclophosphamide and IVMP for the existing pancreatitis and lupus nephritis, absence of APLA or NMO antibodies, and redundancy in the visual symptoms or cortical plasticity. So to conclude, my take-home message is that appreciation of vision loss is not always possible by the pediatric population, but the routine ophthalmological checkup with dilated fundus examination in all pediatric patients is a must. Early detection helps to prevent permanent vision loss, and the most important multidisciplinary approach between the pediatrician, rheumatologist, and ophthalmologist is of paramount importance. These are my references. Thank you.
Very, very, very interesting case, Shogoto. Are you trying to publish it?
So we have tried to publish it, but
Where?
some Actually, I am the presenting author. The
Right.
main author is our
Marina.
consultant, Marina madam.
Right. So,
So
where are
she-
you trying to publish it? This needs to be
at the-
published.
She was trying to publish it in Neuro Ophthalmology journal, but
Right.
some corrections were given,
Yeah, yeah.
so
It's
still
going to come back.
Uh,
So if it comes back from one journal, send it to another journal. But keep at it because
Okay.
this needs to be published. It's a very, very interesting. One thing I would suggest is the HFAs, don't crop it. Never crop a test. Like the HFA, just don't show the total deviation and the pattern deviation. Show the whatever test in entirety. OCT is going to be a problem in such a young age group. HFA again, it's very difficult to now quantify in this particular patient except for VEP. But it's a very, very good aid.
Yes.
As the child grows, then we can, get an idea.
The child is still under our follow-up, and the pallor is still persisting, but her vision remains 6/6, and the color vision remains normal.
No, see, pallor is something, pallor is like RP changes. When I don't find anything, I'm like, write RP changes. Or pallor, it's a very non-specific kind of term. But like you mentioned, cortical plasticity could be one of the reasons why this patient is still not showing any symptoms. But with age, when definitely there'll be a lot of RNFL loss, then, maybe
But
something-
and also some good studies show that early treatment with cyclophosphamide and
True.
azathioprine
True.
is superior to IVMP.
Correct. It's great. It's great on a number of levels. Please publish this.
Okay, thank you, sir.
Thank you so much. So we'll move on to the next presentation by Dr. Kanchan Singh. I'm seeing so many people, but am I in a different hall or something? It's the same hall. Jyoti is there. Dr. Jyoti. So this is she's going to present comprehensive analysis of clinical profile in 6th nerve palsy.
Good morning, everyone. I will be presenting comprehensive analysis of clinical profile of 6th nerve palsy. Adult isolated cranial nerve palsy frequently occurs from microvascular ischemia in the setting of atherosclerotic risk factor. Advancing technology proliferating subspecialties made accurate neuro-ophthalmic diagnosis a widespread reality. 6th nerve palsy is most commonly encountered in both ophthalmic as well as neurological centers. The objective of this study was to find the causative factors as well as recovery rate and finally come out with a diagnostic algorithm for the 6th nerve palsy. We used the method. It was a hospital-based retrospective observational study in which 6th nerve palsy patients were followed for 6 months. Here were the tests which we done in all the patients. And finally coming to the results. Coming to the systemic illnesses, in 61% of the patients we were diabetic, followed by diabetes plus hypertension, followed by diabetes, hypertension and dyslipidemia, and finally only hypertension was seen in only 4% of the patient. In results, vascular was the most common cause seen in 49% of the patients, followed by undetermined cause which was only 16%. Rest other causes were less than 10%. Here the result, we compared the recovery and non-recovery. 87% of the patients showed complete recovery, whereas 13% shows no recovery. There's a box and whisker showing the median age in the recovery group, which was only 58 years, and in the non-recovery group, it was seen more in the younger patients, which was 30 years. The recovery with no recovery was seen in the tumor patients and congenital cases, whereas 50% recovery was seen in the traumatic cases. Rest other causes shows 100% recovery. Coming to the discussion, 6th nerve palsy is one of the most common isolated nerve palsy. Vasculopathic are the most common leading cause, and here's a comparison with some other studies. In our study, vascular cause was the most common cause, followed by undetermined cause, whereas in other study by Menon v. et al., vascular cause was only 5%. And in Rush and Young, Menon and Situla study, undetermined cause were the most common causes. And finally, comparing with the other study, in our study, it was seen most commonly in patients more than 50 years of age, and microvascular disease was seen in them. It may be due to the age-dependent increase in the diseases like diabetes, hypertension, dyslipidemia, etc. And here is a comparison with other study of my recovery rate. In my study, vasculopathy showed 100% recovery, whereas in a study, par by par cattle, it showed only 86.7% recovery, and with rush et al, vascular causes showed 50% recovery. Now, here's the algorithm which we came out with, and finally coming to the conclusions. Idiopathic, idiopathic intracranial hypertension is most commonly seen in 20 to 50 years of the patient, and MRV should always be done in such patients, and more commonly seen in females. Vascular causes self-limiting conditions, so no need for immediate intervention. Although 6 nerve palsy is a benign course with good prognosis, but you should always discriminate from the brain lesions, which is very important for ophthalmologists. In absence of any risk factor, neuroimaging serves as the most important diagnostic tool. Thank you.
Very nice. Thank you. Thank you so much, Kanchan. Very neat, clean presentation. Very nicely presented. This is how you should, start your podium presentations, with something very simple like this. But when you're going in for competitive, let's say, papers or posters, then this probably would not be a topic to choose, because it's been done to death. I mean, topics like this. But why were the previous studies, the cause is undetermined? That's a huge percentage of undetermined. Are you guys brilliant, or they were? So it's very odd, because now with the diagnostic tests, there has to be a cause. So undetermined is a very vague, but it's very, very, very nice presentation. Okay, thank you.
Thanks.
Thanks. So we'll move on to the next presenter, Jyoti. Oh, sorry. I forgot to take. Okay, is this spelling correct or the name correct? It's written Acid Dholakia. It's true, because we had a junior called Acid. So I'm like, there must be something wrong. So, please. So she's going to present a case report on tuberculous osteomyelitis of the skull base, presenting as a lateral rectus palsy.
Good morning, everyone. I'm Dr. Acid Dholakia. So I'm going to discuss a case today that came to our OPD at Santosh Hospital. She was a 22-year-old woman, and she had the basic symptoms of left eye restriction in the lateral movements. She had diplopia and she had headache, and she had been presenting these symptoms since just 4 to 5 days. Later on, she gave the medical history of having tuberculosis, for which she had been on treatment for the past 4 months. Everything, the patient's visual acuity was 6669, and the only problem was that she was having binocular diplopia on all left lateral gazes. Fundus examination was normal in both eyes. So this is a patient. One of the important investigations, that her adenosine deaminase in her CSF was raised. This suggested that she had tubercular infection in the CSF as well. It had spread. After which we went for MRI brain reports, which were done. So there was significant thickening on the left side in left petrous apex, clivus on the left side, and there was also dural thickening, which led to the compression of the cisternal segment of the sixth nerve. So the MRI orbit also showed that left lateral rectus muscle was atrophied, and that there was the compression of the sixth nerve. Based on the MRI reports, we started her off on several treatments, most important of which was that we started her on hydrocortisone injections. They were given for a time period of 3 days, and within 5 days, the patient's condition improved significantly. Now, why this case is very relevant in today's scenario is because very rarely do patients present with very few symptoms of this kind, mainly like binocular diplopia, headache, and difficulty in moving her eyes on the lateral sides. And a quick diagnosis was important in this patient, because tuberculous osteomyelitis of the skull base is a life-threatening condition. So an early diagnosis and prompt treatment were both very necessary for our patient. Thank you.
Very, very nice presentation again. Any idea of how many percentage of total tuberculosis patients present with something like this, with a nerve palsy?
So far, according to, I don't have any Indian studies, I don't have much idea, but the studies that I have referred to, there was about only 1% of the patients who had tuberculosis presented with tuberculous osteomyelitis of the skull base.
Correct. So again, I kind of stress on trying to publish it.
Yes,
Okay.
sir, definitely. We are trying for that, sir.
Because they try to find some unique points. So
Yes,
as you just mentioned that you can't think of any Indian studies. So your line is going to be, this is probably the first Indian study, which kind of points this out.
So it's not the first, but I do remember fewer cases of this sort.
Yeah. There will be some, once you start searching, but then you can try.
Yes, sir.
And there are these two groups. One are the peer review journal, the other the non-peer review journal. So even if it doesn't get accepted in the peer review ones, try and publish it in the non-peer review journals. So
Yes.
you definitely. It's
Thank
a
you so
good
much, sir.
case.
Thank
Very
you, sir.
good case. Okay, so we'll move on to the next, the 10th, Dr. Gauri. Dr. Gauri Deshpande. No, okay. So we'll move on to the next, Dr. Mainak. Please.
Yeah, so good morning everyone, good morning sir. I'll be presenting the case of rescuing a giant overhanging bleb in an advanced glaucoma. So this is a patient, 67-year-old lady, presented to us with the very advanced cupping, already on 4 medications and diagnosed 1 year back. These are the presenting fields of the patient showing absolute scotoma. When she came to us, her BCVA was 612 in the right eye and 69 in the left eye. She had noticed a diminution of vision in the right eye significantly in the past 6 months. Already on 4 drugs with an IOP of 20. These are the anterior segment findings of the patient. Gonioscopy had shown an intermediate angle closure and also 0.95 cupping in the right eye and 0.85 in the left eye. So after discussing the pros cons with the patient, we proceeded with the combined surgery for the patient. The surgery went uneventful, but initially she had a very shallow AC with slightly overfiltering bleb. We did a torpedo bandage for the initial 1 or 2 days, after which the AC started to form and she started recovering. These are the post-op course of the patient, in which post 2 weeks the vision started to improve and it was maintained at a steady state of 6.9 BCVA at 1 year of follow-up with a well-controlled IOP. The problem was the overhanging bleb in this patient, which started to increase post-operatively, and this led to foreign body sensation, watering of the patient, and initially we managed her with lubricants, anti-allergic medications and NSAIDs, but patient was fairly symptomatic. After 2-3 months, we had proceeded with the left eye combined surgery of the patient. Post that also she recovered well, and she had a BCVA of 6.9 that 6 months of follow-up with a well-controlled IOP without any anti-glaucoma medications. So after a year of the initial surgery, we went for the bleb revision surgery for the patient in this eye. So there were definitely the risk involved, the high chances of failure of the bleb requiring anti-glaucoma medication, chances of snuff out, a drop in the visual acuity, and as well as the risk of infection. We had discussed all these with the patient. We went ahead with bleb excision with repair with amniotic membrane and BCL. So these are the surgical steps, and as you can see that intraoperatively we had a well-formed bleb after titration, and we had put a bandage contact lens initially in the patient, because of which the IOP assessment was slightly challenging, and we had started the patient on Dorzox-T. At 6-month follow-up now, she's maintaining a UCV of 6.9, which actually improved from 6.18 after the initial surgery, and she's maintaining an IOP fairly controlled of 16. So these are the post-op fields of the patient. This is 3 years since the first field which I had shown, which is showing a status quo. And we had also sent this for the histopath, which showed a pemphigoid dermatosis. And so basically the overhanging blebs are projecting onto the cornea, which are increasing with the increasing use of the antimetabolites. There are some surgical and the non-surgical methods for the treatment. Yeah, so the take-home message is that a high overhanging bleb, it can be unpredictable and can be seen post uneventful surgeries also. If you do the bleb excision at the right time before the conjunctival scarring has started, so you can salvage the bleb, have a good surgical outcome, and maintain the bleb in a functional state. So you have to counsel the attendants about the risk involved in such a resurgery, and the counseling should be done very meticulously. Thank you.
Very nice. Very nice presentation. This is more into my forte, because I'm a kind of glaucoma. So are you doing TRAPS, Moina?
Yes, sir, absolutely.
You're doing
It
TRAPS?
was operated by me only.
Yeah. Also, it's just the start of the journey. So you're going to encounter many more. There'll be more failures compared to, overfiltration.
Right,
So
sir.
you'll have both. So you got to figure it out. So how did you manage this with? I mean, you kind of excised the tissue,
Yes,
and
sir.
then what else did you
So
use?
conjunctival advancement was, we did slight conjunctival advancement,
Correct.
but since we had amniotic membrane with us, that actually helps it provide you a scaffold also,
Right.
as well as where you cannot stretch it, you can suture it to the limbus, but because of the excess sutures, we had to put a BCL, but we found no bleb leak on table because we did the titration and it was a well-formed bleb.
Right. And the flap sutures, did you kind of play around with it? I mean, was it?
No, sir, we
filtering
did not
through-
modify the flap
You
sutures.
didn't.
We saw that the flap, it was 1 year post the initial surgery, so we found that there was no
It's okay.
scarring. Yes, sir, it was absolutely fine.
So it's very good, very nice.
Thank you so
Was
much,
the
sir.
patient having any difficulty in vision and movement?
So she was having
Okay.
difficulty in movement. It was a, so primary surgery, I always go for a supranasal trab.
Right.
So the bleb had migrated more nasally
More.
because of the torpedo bandage, and because of which her gaze shift was also difficulty, and she was not able to open her eyeball because it was a cystic.
So this was a
web.
pretty big one.
Yes, sir.
Great.
Thank you so
much. Well managed, very well managed. One point again, I would like, because these things keep on happening, but it catches our eye. When you're showing a 24-2, which has such a lot of, scotoma, immediately do a 10-2. Immediately do a 10-2 and, just put them side by side. So the examiner doesn't need to think. Okay. So, Dr. Ravi? Dr. Ravi is also not there. So we're finishing ahead of time. And Dr. Shiv Priya? So I'm going to ask questions again. So we are done actually. I should have taken a A first, then we could have got more time. So we still have, I think, 5 minutes. So anybody wants to ask any questions to any of the other presenters? Sure. Bolo. Yes, that's very tricky. Very tricky. We are seeing a lot of multi-drug resistant TB nowadays. So it's a huge problem. So we are going to face, so there are some of these things which we know are going to be epidemics. One is diabetes, the other is ARMD, third is glaucoma and tuberculosis. So be very careful when you're kind of dealing with, because TB can masquerade as a lot of other things. So the presentation may be something entirely different and you'll be going in a different direction. Yes. you for the wonderful session. Thanks to all the speakers. I mean, it was really interesting. We just finished on time. I don't know how, because I was very late. So we'll hand over the chair to the next session. Please, ma'am.